Hello and a very good morning, everyone. Assalamu alaikum, namaskar, sat Sri Akal. I am Dr. Mukhmohit Singh, MBBS, MD. I specialize in preventive medicine, also called as community medicine or public health. This is my small proposal for containment of COVID 19. It is a small disclaimer is that this proposal is based on personal experience and it does not relate to any prevailing guidelines by any country. For more information on the current guidelines pertaining to control and prevention of COVID 19 cases, please visit the website of the Health Ministry of your own country or the World Health Organization. So, as far as this proposal is containment is concerned, I come from a small town called as Chandigarh in a big country like India, and we will be talking about containment measures, which can, of course, be escalated to any city, any district, or block level or state level, whatever level you're working at. So this proposal, of course, is not intended to make any guidelines. It is just my personal suggestion, of course, which may be used by any people who are in policy making or at authority level. So first of all, we'd like to shift over our concern towards the SWOT analysis. That is the most basic. We try to understand the strength of the problem, the weakness, the strength of the area, the weakness, the threats, and the opportunities. Next is we are going to talk about the prevention level or what is the current problem that we are facing. Next is we will talk about the theme of my proposal, that what is this proposal all about. And next is the main part, that is what everybody would be interested in, that what is the objective of the proposal, what is the plan or what is the actual strategy. And lastly, that is what is the monitoring and the evaluation protocol that we are going to adopt. So, of course, let us first start with the SWOT analysis. I'm just repeating it that we are taking, for example, a small town that is Chandigarh, which is from a big country, India. And this Chandigarh has roughly a population of 14 lakh population, which corresponds to 140,000 population. So that's just a rough estimate for the city. Of course, I'm not talking on the numbers. My main purpose is about the guideline or proposal for the containment structure, which has been taken by many areas. It has been already implemented by many cities in different countries. So first, let's talk about the SWOT analysis. If we talk about the strength of the city, the strength of the city, the strength of the city is a smaller population size and a mild to moderate density. That's what is more important over here. It also has better community involvement. It has better community involvement and more like a closer community. But the weakness of this city, and for that matter, for almost any city, the weakness would be there is a lot of increased amount of transition. So that is where I see a couple of flaws, that many guidelines are saying that we will have a 3 kilometer buffer zone or a 5 kilometer or an 8 kilometer. But I tell you, from my times when I was in hostel, we even used to go 10 kilometers to have a good cup of coffee. So I think the places have just come down and it's easy for people to move or transport. So there is increased amount of transition in terms of the movement of the population, so which I think is a common phenomena for almost every city. And also the weakness is the health system capacity, because I know that currently the health system is already working at 90 to 100% capacity. So do we have a chance of taking care of more cases? We have to make a plan like this. And third is multiculturalism, where I think people from all walks of life, from different religions, come and stay. So that is kind of a weakness, I would say, because multiculturalism actually promotes a spread of any kind of viruses, because different people will have different cultural beliefs, and it's a kind of a tricky task to have everyone on the same common platform. And then we talk about the threats that we have. So what are the threats? The threats that we are facing currently is a COVID threat. Before you just dump this guideline, I would like you to just make a presumptive model in your mind, the case scenarios that we are seeing in New York, USA, or Lombardy, Italy, and to a lesser extent in few other countries, why was this happening? So we'll just be talking on those terms. So of course the threat is this, and this is my personal assumption that roughly approximately 20 to 25% of any general population may actually be infected with COVID. And I think the numbers, you can do smaller or similar mathematics in your own mind. If you talk about the opportunities that we have, are very less, and they are in fact limited, and that is where we all are trying to strike the balance. The opportunity is a type of the workforce that we have. The workforce that we have, what do I mean by the workforce, is that roughly approximately 30 to 40% of the population is young. So you can take those young population into hand. We also have higher farm areas and things like this. Next is, let us talk about the prevention levels or the problem that we are facing. Let me take a top to bottom approach. Top to bottom approach. What do I mean by top to bottom approach? Let me first talk of the tertiary prevention. What do we mean by tertiary prevention? Tertiary prevention is, it means that you are basically tackling the complications. So which has already been done by many medical colleges or medical schools or tertiary level hospitals. So provision of ventilators, provision of ICU beds, that's already of concern. We'll talk of that in some other time, but right now the main objective of the proposal is just to highlight the problem. So tertiary level, we have a problem of tertiary prevention. Secondly, we come over to the secondary prevention strategy, where you want to early diagnose and treat. So this is already done by many people. We are trying to take a double prong strategy, that is, we are doing self isolation to people who are like COVID suspects, and we are also having increased health capacity. We are trying to increase the health capacity. It is basically early diagnosis and treatment. So for this, we have to increase the testing capacity. Lastly, we come over to the primary prevention, and this is the whole objective of my talk, that we are going to talk about the primary prevention. This is currently being done by mass communication methods, using media, using radio, using television, using mobile phones, using Facebook, everything. But I would like to lay stress on this, that we are not doing what we are supposed to do for primary prevention. The problem is inefficient methods. The problem is, I would like to highlight again, currently the problem is insufficient efforts, or or you can say ineffective strategies. So we need to be more aggressive. We need more aggressive on this. We need to be more aggressive. So that's what the whole game would be about. So third is, let us talk about the theme of my proposal. The theme is very simple. I've already given you an introduction that what I'll be talking about. The theme of my proposal is three-pronged strategies. The theme is, we are going to take 1, 2, and 3. 1, 2, and 3. The first theme is to promote social distancing, that I think we already are doing. The second theme would be to enhance the testing population, the testing number. Of course, testing has its own problem of having it has a low negative predictive value. That means it has slightly higher number of false negatives. So there is a slightly higher number of false negatives. So of course another issue we are going to talk sometime later. But right now, the theme is to increase the testing number, to increase social distancing. That is what is primary modality. And third is, what my main objective of this proposal would be, to have line listing of cases. So that is what I want you to draw your attention to. Are we doing this? Are we doing the line listing of the cases, or maybe at risk people, So I want you to understand and make a point over this, that please write or listen to it with a good amount of concentration. I want to find out that who is diseased. I want to find out who may be diseased, and I want to find out who can be diseased in future. So can be diseased in future is what you want to predict. So COVID is an infection which I think it's common sense for us to understand that it has a potential to cause enormous big amount of economic and health imbalance. We need to focus on who may be infected and who can be infected. Who is diseased will eventually land up into the health system. So we want to find out who can be diseased and who may be diseased. We want to promote early detection and also primary prevention by focused health communication on a group approach or individual approach rather than a failed mass communication. So mass communication, I know the government is doing, the social media is doing, everybody is doing, but I hope you all understand that it is not as effective as it could have been. India is a country which is known for the grassroots level workers. We are known for asha workers, we are known for anganwadi workers. We have a very robust primary healthcare system. We need to use that system, we need to mobilize that system. Please listen to me very carefully, all the people who are in authority, that if we have done this during election time, we have done this during pulse polio time, we have done this during census data collection, we have done this during NFHS data collection, why cannot we do community mobilization now as well? Because this time the objective is to keep the people distant while testing. So let me just this was the theme basically, that we should have three things: social distancing, increase the testing number, and line listing of cases. Next is, let us come to the main part. What is the objective strategy of my proposal? If you talk about the objective of my proposal, if you talk about the objective of my proposal, the objective, as you have might have understood right now, I want to propose that let us do line listing of the cases or high risk cases, because then only you're going to find who may be diseased, and finding the person, finding the individuals with risk, and giving them mo- communication methods based on individual communication methods. So how to do this? So I would like to propose to you a para healthcare or associated. So now we come to the strategy how we do it. So I would like to propose to you that para healthcare, what do I mean by this? This might be a new term for many of us. Para healthcare, what do I mean by para healthcare workers? As people who are related to healthcare but they are not health professionals. For example, school teachers, they help us in finding out blindness, they help us in finding out malnutrition. They have already done that. So we have school teachers, we need social workers, we need community workers, community supporters, we need people who are working in rural development areas, rural development. So we need these type of people, and of course teachers, so they can build up a team of para healthcare workers. So what we can do is action number 1. So the action number 1, I'm talking at a very micro level, micro planning level, that we need to build teams. The teams will be composing of 2 persons per team for a roughly, let us say that the block level in India, we are having block levels. So block level has a rough population of 100,000 population, which is corresponding to approximately 20,000 dwelling units. It could be more than 20,000, or let's take an approximately 20,000 dwelling unit based on a family size of 5. It could be more or it could be less. Anyways, so let's focus on this. For 20,000 dwelling units, one team can approximately do a house visit of around 100 to 150 houses per day. We are going to ask them 5 questions. 5 questions will be asked by a single team, and that question would be: one is number of members and the age. Second is any travel history. Third is we should talk about any flu, like symptoms. Any flu like symptoms. What do you mean by any flu like symptoms? I want to stress upon that. Let us take, for example, that what if we enhance the COVID definition, that any person with flu like symptom would be taken as COVID until and unless proved otherwise. That means any flu like symptom is basically a high risk case for us. Travel history is again a high risk case for us. Next is we are going to talk of any contact history with person with flu like symptoms, and last is we need to take out the information in terms of the mobile number or contact detail of any person. So it is not necessary to talk to every family member. We just knock the door, the team would knock the door, talk about these five topics, and that's all. So these are going to take the testing of all high risk and regular follow up cases, and they are going to take the data, put it into a spreadsheet, and this will be being escalated. The second action will be taking this data and escalating it to action number 2. The action number 2 is formulation of a COVID link center. The action number 2 is formulation of a COVID link center where we can take out 20%, 20 to 30 people with good commands in computers and communication. These people can also work from home, and this data will be shifted to the COVID link center. So now what example I'm taking is, let us say that this is your town. So in this town, let us say that you divide your town into 8 zones, for example, or any X number of zones, 9 zones or 10 zones. So you take teams from this zone, and this team will be giving all the data, will be collected and sent to a link center. The link center is going to make the spreadsheets and is going to do the line listing of cases, and we want, the main focus is we want individual communication with the patients, and we want individual communication with the patients, and we want to have tracking of high risk cases, and we want to have home isolation. Rather than building a community isolation, we want to promote home isolation of those cases. So what I feel is that having a community isolation would maybe increase the chance of spread, because once we are taking all the high risk cases and putting them into a single temple or a masjid or gurdwara, or putting them into schools, making them live together, you are probably increasing the chance of infection to other people as well. Moreover, we will have to manage them, their food, their kitchen, their toilets, washroom, everything. So that may increase the chance of infection and chance of spread, and may enhance the community participation, may enhance the community transmission. For that reason, I would suggest that let us go with home isolation if at all possible, to have these teams ready and to have this COVID link centers, and they are going to have a linkage between the community and between the government. So, who can be the COVID team members? This has to be chalked out at a very micro level. Plus, in case your city has those Zomatos or the Swiggy mobile applications, or those people, the home delivery services, they can be brought together, and they can be brought together, and they can be brought together and involved in this, for providing them messages towards home isolation, or providing them people who are home isolated, providing them medical care or health care. So in that case, we will have at least a line listing of all the cases, and we would know that on whom to strike, who may be diseased, and who all can be at risk. So, with that, the main purpose of this proposal is to establish rapid response teams and COVID link centers, rather than isolating them in community spaces, we need to isolate them in home spaces. So I hope that we all come out of this crisis with the least possible loss and the damage to our community and people